Okay, so we are talking about incidentally discovered adrenal tumors of the adrenal cortex. And this tumor stands somewhere between the non-functioning adenoma and the adenoma responsible for Cushing syndrome. So, the main characteristic of this tumor is that they have a cortisol secretory autonomy. So autonomy is a different paradigm than secretion. It can be autonomous and highly secreting. It can be autonomous and moderately secreting. And this is exactly what we are talking about. So according to the recommendation of the European Society of Endocrinology, the guidelines, to which I had the pleasure to participate, the screening for these tumors is based on the 1 milligram dex test. You have to confirm it. You have to look for the presence of comorbidities potentially attributable to cortisol. You have to do, it's recommended to do a second test and then to confirm a CTH independency with the measurement of morning CTH, secreting CTH. So I won't go into the details of the diagnosis, you already know this. And in terms of epidemiology, and Vipke mentioned that this morning, that the majority of adrenal incidentalomas are benign tumors, and a minority of these are secreting also, but MAX is probably one of the most secreting tumors in the landscape of adrenal incidentalomas. It may account for 20 or to 30% of adrenal incidentalomas, so it's quite a frequent feature. What do we know from the literature? We know that if we compare, this is a meta-analysis also performed by the AC, if we compare the prevalence of some comorbidities like diabetes, hypertension, and dyslipidemia to non-functioning adenoma, I mean by non-functioning adenomas that do suppress cortisol level below 50 nanomole per liter following the 1 milligram dex test, you can see that the prevalence of diabetes, hypertension, and dyslipidemia is increased. We know also from some follow-up studies that there is with time an increased prevalence and incidence of cardiovascular events in this tumor as compared to non-functioning adenomas. Last, some studies have shown also that there is an increased mortality rate as compared to non-functioning tumors, increased mortality rate due to cardiovascular event, infection, but also cancer. Okay, so these are, I would say, cross-sectional evidence. And what tells the guidelines of the European Society is that, of course, observational studies cannot prove causality, and interventional studies are needed to prove the causality between these comorbidities, this event, and the presence of MAX. And interventional studies published at the time of the publication of the guidelines only suggest an improvement in hypertension, glucometabolic control, and dyslipidemia following adrenalectomy. Indeed, most of these studies had methodological flaws, multiple. I will illustrate some of these, resulting at the end in a low quality of evidence. So what was recommended is to perform some more methodologically robust randomized trial to assess the potential benefit of surgery in this patient. And of course, you can understand to do prospective study on hard events or even mortality is not feasible. So it was recommended to carry study with defined surrogate endpoints like hypertension or evolution of type 2 diabetes that can be well controlled with standardized treatment regimens throughout the study. So this was the recommendation in terms of future studies to conduct. Okay, so we will focus mainly on hypertension, and this is the analysis, the meta-analysis that performs the AC at the time of the publication. And you can see that if you compare the evolution of hypertension in patients with MAX between those that have been operated versus those that have not been operated, in almost every study, it falls in favor of surgery. Surgery improves hypertension as compared to conservative treatment. But you can also see that we can discuss some methodological flaws. You can see that a number of studies were retrospective with, of course, the intrinsic selection bias of patients. There was a very small number of patients and only studied, and only 2 randomized control at the time of the guidelines. 2 more prospective studies have been conducted then, and I will just focus a little bit on this randomized study for surgery. So one is quite old with, I would say, disputable criteria. We can consider this 3-1, Italian, South Korea, and a multicentric study involving, I think, a UK center. I think Florian is one of the authors. And so the criteria for selection were the actual criteria for diagnosis of MACs, so it's okay. The duration of the follow-up was variable between 6 to 48 months. In terms of the criteria for improvement, it's a little bit more muddy. It's a composite criteria looking at the blood pressure, the hypertension class, and treatment changes, composite criteria. And the results of these 3 studies are that, again, in this prospective study, surgery does better, improves hypertension as compared to the improvements seen with a conservative treatment. We don't know in these 3 studies there were true remission of hypertension, like we know, for example, in Cohen's in primary aldosteronism. But I want to focus on this 4 prospective study to mention that, again, there was a small number of patients included, both in the surgery and in the conservative arm. And more importantly, 2 major criticisms. Blood pressure was measured at the office with an armband. We don't know by who in general. And I've learned from the hypertension guy who helped me to set up this protocol that it's probably the worst time to measure hypertension is at the office of the doctor. Okay? And another major criticism is that there were no standardization on anti-hypertensive treatment, meaning that after surgery or not surgery, patients were sent back to their endocrinologist or cardiologist that was free to adapt the drug or not. So indeed, we can do an accurate comparison between the 2 strategies. So this is in this context that I propose the Charasic trial. So I want to mention it has nothing to do with the previous president of France, Chirac. The translation of that is surgery, for surgery, of subclinical cortisol circulating incidentalomas. So what are the merits of this study? It's a prospective, it's a randomized study, surgery versus conservative treatment for unilateral incidentalomas associated with MACs and hypertension. And the 2 methodological points, important one, are that we standardize the medical treatment and we perform, or at least try to perform, an accurate evaluation of the blood pressure endpoint. So it was mainly focused on blood pressure. So as you can see, a number of French, but also German and Italian centers participated to this study. And so let's go into the details of the protocol. So all patients had to have an adrenocortical nodule of at least 2 centimeters in size and to have the current criteria of MACs, impaired suppression of cortisol following 1 milligram dex test, but also a low or suppressed morning ECTH. And there was first a run-in phase. So the run-in phase with monthly visit that lasted, depending on the patient, from 2 to 13 months. The run-in phase had 3 aims. The first one was to confirm hypertension using ambulatory home blood pressure. It means that the majority of patients that we saw were already treated for hypertension. We withdrew the drug just to make sure that they have hypertension. And to measure tension, we give them to all those patients this home run, and they perform, as recommended by the European Society, multiple home blood pressure measurements 3 times in the morning, 3 times in the evening, during 4 consecutive days. And we know that this assessment of blood pressure is much more correlated to cardiovascular events than blood pressure measured at the office of the doctor. So we first confirm hypertension, and then we started to control blood pressure in each patient with a standardized stepwise predefined algorithm, starting with 1 drug, 2 drugs, 3 drugs, depending on each monthly visit. And when at 2 consecutive visits, blood pressure was controlled, we then switch the patient to the randomization phase. And at the end of this run-in phase, so confirming hypertension and controlling hypertension with a standardized treatment, medical treatment, we also perform a secondary endocrine evaluation to confirm the persistence of MACs. Then, during the second phase of the study, patients were randomized either to surgery or conservative treatment group. And during the post-operative phase, that post-randomization phase that lasted for 13 months, we try exactly to decrease the antihypertensive treatment in the inverse way that we put it at start. So it means that we try to withdraw the latest drug given, then another one. And as you can understand, our hypothesis is that if MAX was responsible for hypertension, our hypothesis was that we would be able to decrease the amount of drugs taken by the operated patient while maintaining a normal blood pressure. And on the inverse, we speculated that in non-operated patients, withdrawing drug, hypertension would recur. So this was exactly what we did, systematic attempt to decrease stepwise the treatment in both groups while maintaining control of blood pressure. And so our primary endpoint, and the study was powered for this, was the possibility to reduce the antihypertensive treatment while maintaining adequate blood pressure. So this was I would say, the causality goal. And of course, we also assess a number of secondary endpoints about hypertension. Are we able to cure patients with surgery? To what extent can we reduce the drug treatment? Also, we perform some 24-hour ambulatory blood pressure at start and at the end, and also some metabolic parameters. So this is the flow chart of the study. I won't go into the details. I just want to point two elements. The first one is that at the end of the running period, we had to withdraw 11 patients that were not hypertensive. I remember when we withdrew the hypertensive drug, at the end, the patient had no hypertension. I can tell you we followed this patient for months and they were really not hypertensive. So it was probably a white coat effect. So think about what would happen if we had included this patient in any group. And also, and this is more and more known, at the end of the running evaluation, at the revision of MAX, some patients had no more the biological characteristic of MAX. So we know from some studies that MAX also, since biological criteria are close to the borderline, sometimes patient can be considered as non-secreting or MAX. So this is what happened. So at the end, we had 52 patients that were randomized in two groups, and a very limited number of patients dropped out. So at the end, we had 23 patients in the surgery group, 25 in the control group. So this is the characteristics of the patients. They are, of course, equivalent between the two treatment arms. I just want to mention some characteristics. Of course, it's female, mostly females, with a median age of 60 years old. You can see that the incident telomere is around 3 centimeters in size. I just want to emphasize the fact that in terms of number of steps of the antihypertensive treatment, the median is 3. And you can see here that more than 1/3 needs at least 4 antihypertensive drugs. So it's not mild hypertension, it's truly severe hypertension. You can see also that more than half of patients are obese. And if we also add overweight, it's 2/3 of the series. And also 2/3 of the patients have either glucose intolerance or diabetes mellitus, and almost all have dyslipidemia. So this is the classical characteristic of a patient with MAX with a numerous cardiovascular risk factors. Okay, so in terms of hormonal data, I want to insist also the fact that it was a criteria for recruitment. These patients have normal UFC at the time of the recruitment. So the color code is red for surgery and gray for conservative treatment. You can see that at start, they both do not suppress following the 1 milligram dex test, and they all have, as I mentioned, a low or suppressed morning STH value. What happens after surgery? UFC is still normal, so at the end of the 13 months follow-up period. In terms of overnight dexamethasone, of course, patient operated now will suppress cortisol, while the others don't. And in terms of morning STH, of course, morning STH increases in operated patient. In other terms, patients who have been operated no longer have biological MAX, while non-operated patients keep their MAX criteria. So this is the blood pressure, systolic blood pressure in home measurement and systolic blood pressure at randomization. You can see it's equivalent between the two groups. At the end of the study, you can see again that blood pressure is controlled in equivalent way for the systolic and diastolic between the two groups. Now, what happened to the treatments? So this is the number of lines of anti-hypertensive treatment at start, at randomization. And this is what happened at the end of the study. We have a very significant decrease in the number of drugs needed in the operated patient, while it did not change in the non-operated patients. In other terms, this is another way to illustrate what happens in terms of drug treatment in the adrenalectomy group with the different steps, different lines of treatment. You can see in almost all patients, there is a decrease in the requirement of anti-hypertensive drug, while in the non-operated group, of course, some patients have a decrease in the number of drugs, but the majority, there's no change or even a worsening. Okay, so in practical terms, so I think the causality is now proven. So in practical terms for the doctor, what does that mean? That means if we consider systolic home blood pressure measurement, 52 of the patient, half of the patient adrenalectomized do not require no more hypertensive drug. So they are cured of hypertension. 21% have still need drugs, but there is a decrease of at least one drug requirement, and 27% there is no change. And among the conservative group, there is the possibility to decrease blood pressure in 16% of the patient, and in 84%, there is no change. So we also perform, as I mentioned, systolic 24-hour blood pressure measurement. And so the results are less good because it's a more stringent evaluation of blood pressure. And I can recall you that we did not adapt the drug to 24-hour blood pressure measurement, only to home blood pressure. But still in this group, in the operated group, we have 35% of patients that are cured of hypertension, 17% improve, and half in whom we could not change the number of lines. Importantly, when we look at the body weight evolution, there is a tendency toward the decrease of body weight BMI in operated patients, contrary to conservatively treated patients. But this difference is not significant. It means that the improvement in blood pressure is not due to non-specific effect, such as losing weight. With regard to body weight and to obesity, let's have a look at the randomized study published today, because the meta-analysis did not show very obvious effect of surgery on body weight. And as I showed you, most of these patients are obese. So if we look at the data about obesity, you can see the number of patients studied in the three randomized study is very low. And when we have the results, there is no specific data on obese patient. There is data about body weight on the whole cohort. But I mean, it's not very important. I mean, when you treat, if you want to operate a patient, you won't operate a patient to lose weight if he has no obesity at baseline. So, well, regardless this point, we can see that in two studies, it was found no significant body weight loss, while in the Korean study, the largest study, there was an improvement. And in our study, you can see that we also measured in a subset of patient fat mass. See that the evolution of body weight is not statistically significant, different between the two groups, but still it's very heterogeneous. Some operated patients lose a lot of weight, while others don't. So very heterogeneous. And if you consider the classical parameter of criteria of body weight loss of more than 5%, we had 21% of the operated patients who improved body weight and only 5% in the non-operated group. And so this was non-significant. Let's spend some time on an unpublished data that is glucometabolism. So this is also the result of the AAC meta-analysis about the improvement of diabetes. And again, in the retrospective study, but with the bias of being retrospective, overall, there is an improvement of diabetes in patients that have been operated compared to those that are conservatively treated. What about prospective randomized study? Again, we found these 4 studies. Now, the number of patients with diabetes is very low, very low. In terms of improvement criteria, it's very heterogeneous. We can consider glucose level, HbA1 class. I was unable to find the literature, but what does that mean, the HbA1c class, or the treatment changes. And again, in this study, we have 3 studies that say that there is an improvement, significant improvement with surgery, although there is no data, no specific data on diabetic patients. Here we only have 8 patients, okay? And in the multi-center study, the last one is on a very limited number of patients. It's non-significant. So I think that the evidence today for the improvement of diabetes with surgery in this patient is really debatable. And what about our study? So we had 16 patients with either glucose intolerance or diabetes in the surgery group versus 18 in the conservative treatment group. It's not big numbers, but still, I show you the data. You can see that HbA1c at Rondo at the end was, I would say, acceptable with regard to the age of this patient. And we defined an improvement if there was a fall in HbA1c of at least 0.5% or stable HbA1c with a 50% decrease in anti-diabetic drug daily dosage. So what happened? Suspense. Okay, here it is. In terms of improvement, we had 44% of operated patients improve their diabetes versus 33% in the non-operated group. So it's absolutely non-significant. So in other terms, about the benefit of surgery in this specific cohort of patients with unilateral adrenal of at least 2 centimeters, max with a low CTH, we can calculate that to achieve 1 case of improvement, it will be necessary to operate 5.8 obese patients, 4.3 diabetic patients, and only 1.6 hypertensive patients for a decrease of at least 1 step in their antihypertensive treatment. So very heterogeneous results, although apparently the benefit of surgery is more evident for hypertension than for other comorbidities. So of course you have seen that it's very heterogeneous. So the next question would be, is there any criteria to select the good candidate for surgery, the patient that will be improved? So of course our study was absolutely not powered to answer to this question. So we only had a look to our cohort, and we separated 2 groups: the patient amongst the operated patients, the ones that were cured for hypertension, versus those that were either not improved or still needed some anti-hypertensive drugs. So of course, we did not start on such small numbers, but we did not find a characteristic in terms of prevalence of obesity, diabetes, the number of drugs that start, the endocrine parameter in terms of cortisol plus 1 milligram dextrose or the CTH and so on, the value of blood pressure, so nothing. Also the occurrence of corticotropic insufficiency following surgery. The only parameter that looks different between the 2 groups, it's the assumed duration of hypertension. Of course, it's assumed because we don't really know. We know when it has been found, but we don't know when it started. And of course, this is also a reminder of what has been published in Primary Aldo, where we know that the possibility to cure patients from hypertension depends also on the duration of the hypertension. So here are my conclusions from this study. So first, I think that it shows unequivocally, that MAX is a cause of endocrine hypertension, that surgery is beneficial for the majority of hypertensive patients, especially if hypertension is recent, that of course we need more study to find predictive parameters for the good selection of patients for surgery, that the impact of surgery in body weight, diabetes, and dyslipidemia remains, for me, controversial. I think we need more study on these topics, like design a little bit like the Charest trial. Of course, we only look at hypertension, and we need to assess the benefits of surgery on the heart cardiovascular events remains to be proven. And of course, this study doesn't solve a more complex issue, that is the therapeutic approach of MAX in patients with bilateral right tumors. So with now, I thank you for your attention, the investigator. And usually people show a picture of their hospital. Now I choose to show you the Dune du Pilat, close to Bordeaux, which is the highest sand dunes in Europe. So this is the Place of la Bourse in Bordeaux. And this is not my hospital, it's Saint-Émilion, close to Bordeaux. And where we elaborate very good anxiolytic drugs. So, thank you for your attention.
Thank you for this fantastic overview. Are there any questions?
Thank you very much. That was super. This is not related to your study, but I'm just interested in max and cyclical hypersecretion of cortisol. Do you or anybody else have decent data on the prevalence of this compared to cyclical Cushing's from the pituitary or normal adrenal Cushing's?
Okay, you mentioned the cyclical max. Yeah.
Yes, it does max cycle, basically.
Yeah. Well,
you had 5 out of 59.
Yeah. So I don't know. Well, I guess it could be cyclical. I think there is a unpublished work from NSAT showing, I don't think it's published, the changes of categorization of the patient with time, with repetition of biological assays. Well, I think, I think one major issue is also the reproducibility of the 1 milligram dex test. Because the criteria that we have for max are very fragile, I would say. When you have a high UFC, in the case of overt Cushing syndrome, it's very easy to characterize it cyclical or not. Or it's easy. You can demonstrate it. It has been demonstrated many times. When it's max, you don't know, was it a false positive of the test and now a true positive? So it's complex. I really think at least that some patients do fluctuate between a state of max and less max. But the criteria are so fragile that it's very difficult.
Yeah, thank you.
Thank you very much. I wanted to ask, did you have any information about renin activity or renin levels in your cohort in terms of the patients that responded better from a hypertension point of view to the surgical intervention?
Okay, very good point. So the question is there aldosterone secretion, co-secretion? So we excluded primary aldo in 75% of patients. And we had, I think by heart, 12 patients or 13 patients in whom we didn't have data on renin or aldosterone. But fortunately, 10 of these 13 patients were operated on. So we were able to look back to the histology and CYP11B2 immunostaining in the adrenal glands, and there was no staining. So at the end, we only have 3 patients in whom we don't know the data about aldosterone co-secretion, but these 2 patients had tumors more than 3 centimeters and no baseline hypokalemia. So we guess that they did not have a primary aldo associated. So maybe if we had performed on steroid metabolism analysis, we have found something on aldosterone or precursor. But regarding the classical criteria of primary aldo, I think that in the vast majority, there was no obvious secretion of aldosterone associated. That could not account for the results.
Yeah, Antoine, obviously, absolutely brilliant study. And I think you make a very important point that's also been shown by other studies in other fields, like the importance of the design and of the run-in phase. Yeah, because you need to define what your starting point is and what your intervention is. Yeah, like sort of, I compare this with a CAH study that we did with Richard Ross, where, the run-in to have the patients come in regularly and therefore remind them taking their medication and stuff like this, that already is very important as a point of care. And if you don't define this, then you lose the effect. And so congratulations on the super design.
Just to thank you to expand your commentary. So there was no standardization of the 1 milligram test. So everybody did it in his own lab. So it's different assays. So it's also another point of fragility of discussion. But still, since they had low, I think they had low CTH. It's an important parameter. And maybe the last thing I want, because this is not written anywhere, but I want to say it. As you have seen, our patient had a tumor of at least 2 centimeters in size. Okay. In max, we know that these 3 centimeter tumors produce very little excess of cortisol, as compared to to tumors that give a full Cushing, they have the same size. So what does it mean? It means that the intrinsic stereogenic activity of each adenoma cell is very low in max as compared to those in overt Cushing. So it means, for me, that you can't have max with a 1.2 centimeter tumor. I think it's impossible. And there are data about the relationship, the correlation between size and the level of cortisol post-dex. But I've seen there are papers where they categorize max for patients that have a 13 millimeter tumor. For me, it's impossible. I think in this instance, it's a false positive of the DEX test. So I would not go to operate a patient with a 15 millimeter adenoma characterized as max based on just 1 milligram DEX test. I would not believe it. Well, this is my opinion, personal opinion.
Thank you very much. Wonderful talk, and thank you for the study. Just wondering, any of your patients become adrenally suppressed after the surgery? Do they need any exogenous steroid afterwards, post-operatively?
Thank you for this question. Yeah. So this is also very intriguing because we assessed residual adrenal function on the 4th day following surgery. We had also a protocol not to give them a huge amount of hydrocortisone at the time of surgery. They only received 150 milligrams at the time of surgery with a decrease to 70 milligrams the 2nd day and so on. So not big amounts of hydrocortisone. And we evaluated them on the 4th day, 4th to 5th day, with a baseline serum cortisol and with a SST, short syntactin test. And despite the fact that all these patients had suppressed plasma CTH or low CTH at baseline, only 65% of these experience corticotropic insufficiency. So we had to give hydrocortisone to only 2/3 of this guy. And it's the same in the literature. You have patients that have the characteristic of max, but unexpectedly, they do not develop corticotropic insufficiency. And also the duration was very heterogeneous. Some patients, I think the median duration of corticotropic insufficiency was 100 days. But still, at the end of the study, after the 13 months, we had 2 patients that were already on hydrocortisone. So it's very heterogeneous. We didn't find correlation with the baseline parameter, with the comorbidities. And yeah, so it's a little bit mysterious for me. But of course, you have to evaluate this and you have to treat your patient with hydrocortisone. By the way, I never experienced, and nobody in this series did experience a glucocorticoid withdrawal syndrome following max. I'm very surprised when I see some paper from abroad, the Atlantic Ocean, talking about 50% of GWS in patients with max. I've never seen that. Never.
Thank you. As Vibke says, I really like the run-in of your study. I think it's really helpful, the way to help interpret the results. But I suppose my question is, I still don't know yet whether I should change my practice and who I refer for surgery with max and hypertension. So what are you doing now in real life? And that's considering we're in a sort of resource-constrained health service here. And if I refer everyone with hypertension and max for surgery, who am I not going to refer?
I'm sorry, I did not catch your point at all.
Who are you referring for? Have you changed your practice?
Yeah.
In terms of referring for surgery, and should we in the NHS with restrained resources?
I hope you will to somehow change your practice if you did not operate patient. Now, I think
you said that only 36% have a reduction in their hypertension. Have I missed it?
Yeah, I think it's a complex issue because you have to consider a number of parameters, also the age of the patient, the comorbidities, and so on. So you have to consider that you only improve or you make your hypertension. But I think it's the same reasoning in a patient with primary aldo. You have to decide which patient is a good candidate. When you don't have a precise algorithm to know who is a good candidate, I think that you have to consider a number of parameters. Probably, as we mentioned, to do several tests to make sure that it's not a fluctuating max, that it's truly established, that your patient has a real hypertension, and to see also the age, comorbidities, and so on. And so, but yeah, I think that it may be profitable for some patient. And also the cardiologists have learned this, that even withdrawing one drug, in a not curing patient, but withdrawing one drug, with regard to the auto-aggravation of blood pressure with time, it can be profitable can be clinically significant to reduce one line. But of course, if it's maybe a 90-year-old patient, I wouldn't go for that.
So
I don't know if I answered to your question.
one more question here.
Thank you for the talk. My question was, I understand that the study looks at unilateral disease only.
I don't hear you at all.
Can you?
Oh.
Other way around. Is that better? Yeah. Yeah, so I understand that the study was on unilateral disease.
Yeah.
But I was wondering what you think in primary bilateral macronodular hyperplasia and how that can progress to MAX or Cushing's. How would they possibly benefit from surgery?
I refuse to answer to this question. I've been invited to talk about unilateral one. Now I think it's much more difficult. I'm not aware of any prospective study, only experience of group. So of course, what is clearly stated in the recommendation is not to perform bilateral ectomy, not for MAX, but you can decide to operate one if there is an asymmetry. It works in some time. It has been shown to work in overt Cushing CTH independent one. Far less data in MAX. You can try also drug. I mean, in each international congress, in the workshops sponsored by the industry, there is always one guy who presents a beautiful case of MAX treated with some metyrapon or some osilodrosat, and it works perfectly well. But I'm not aware of any serious data or study to date. So I can't answer. Sorry.
Antoine, that's lovely talk, as always. Can I ask you about a third way of treating this, which is a 10 p.m. or 9 p.m. dose of metyrapone? Because you showed nicely that the urine-free cortisol burden is not high, but the physiological problem is overnight cortisol secretion. And we've done for a long time just giving patients a 9 or 10 p.m. dose of metyrapone. And if you get a very good blood pressure and or HbA1c response, it gives you momentum that they might get that out of operation. It's quite a leap between doing nothing and abdominal surgery. And there is a third way, which is just to give a nighttime dose of metyrapone. Do you have any comment about that or any experience of it?
Well, I don't know. I would say that giving, well, you can consider it on different aspects. First, there is some evidence, but small evidence, that in this tumor there is a small increase in cortisol in the late afternoon or evening. But very little later, there is a De Bono paper from John Dewey Price on 8 patients in each group. They show a statistical difference, but when you look at the error bars, it's statistically different, but it's not a huge difference. So if you have to give evening drugs, what will be your endpoint? How do you titrate the drug amount? What is your parameter? So it's very complex. I've tried to give metyrapon or ketoconazole to some patients that did not want to refuse surgery, but how do I titrate that? If you titrate on blood pressure, it's quite difficult. So maybe you can titrate on the CTH in patients that have a suppressor CTH at baseline. You wait for CTH to increase. So this is a good parameter, but it's not. I don't feel very comfortable in this instance. Now, maybe with regard, and you can consider the cost. What does mean also the cost of the treatment, one surgery and less drug versus giving metyrapon or ketoconazole or Isturisa for years. But maybe the good trial would be to see if a short-term treatment, I don't know, 6 months treatment with steroids inhibitor that would be able to at least from biochemical perspective, increase the CTH and see if there is any improvement, clinical improvement, maybe to select this patient for a second surgery. But all these are speculations.
Yeah, thank you. Fabulous talk. I just have a simple question about the diabetic patients because whether their HbA1c, improved.
Yeah.
Because there are many patients with diabetes that are resistant, that they do not respond to the anti-diabetic medications, and then they are found to have, MAX. And I just wanted to know, I know it's a limited sample size, but still, if you had data on the improvement in glycemic control.
So in this study, during the run-in period, all the investigators were encouraged, well, patients saw the diet, aside the hypertension endpoint, patients saw the diet and they were, at each visit, they had counseling for lifestyle advice and so on, and adjustment of the treatment. But following surgery and contrary to hypertension, there was no standardized adaptation of diabetes treatment. So we were not able to standardize everything. So it's a major drawback of the data that I show you on diabetes. But we did not see a real improvement. Well, we saw also a 30% improvement in the non-operated group, meaning that the recommendations that were performed, that the patient were also followed more frequently. And so this probably also had a consequence in terms of control of diabetes. And in all, in number of diabetes trial, in the groups that are more frequently followed, now patient consultation, usually even we don't change the treatment, it improves the control of diabetes. So it may have play a role. But I won't comment on the different papers that have been published in diabetes this year, showing that you can treat with mifepristone patient with impaired DEX test. For me, it's a scientific scandal.
I think one last question and then we have to move on.
How did you lateralize the cortisol excess, and did you do histopathology to confirm that you'd taken out a cortisol secreting lesion after surgery?
Did we perform dexamethasone measurement? No, I didn't.
For lateralization, how did you decide? Was it just radiologically on a plain CT scan?
Sorry?
It's a unilateral incidental over.
Oh, yeah. No. Well, all patients here had a unilateral tumor. The contralateral was checked, and it had to be, we tolerate patient with a small nodules, but less than 1 centimeter on the contralateral side. And so it's really unilateral. This was your point? Well, we confirmed after surgery that there is a cortisol suppressibility and increase in the CTH. So it shows that the adrenal gland was not playing a role. Is it your question? Yeah. Okay.
Thank you very much
Thank you very much
for this fantastic talk.
Afternoon, everyone. My name's Sophie. I'm one of the registrars at BART at the moment. And I just wanted to talk you through one of the cases that we've seen recently. So this story starts in December 2023, and we received a referral from the Homerton Hospital. It's a 49-year-old lady, and she'd had an incidental finding of a right-sided adrenal nodule, and this was picked up on an MRI liver that was requested to investigate possible fatty liver. She then had a dedicated CT of her adrenals that was done at Homerton Hospital, and this had been reported as a 2.5 centimeter lipid poor adenoma. And she'd been seen in clinic at Homerton, and they'd done some functional testing, and she failed to suppress on an overnight dexamethasone suppression test. And we brought her over to BART. So this clinic appointment happened in January of 2024. And in terms of history, she'd had symptoms for about a year. She'd noticed a change in her face shape and described some facial puffiness. She'd noticed weight gain, and this was particularly around her abdomen. And she'd said there'd been no appreciable change to her diet or her exercise regime. She reported feeling very fatigued, and she'd also had 4 falls in the last 3 months. And she'd attributed this to some weakness and just her legs giving way. She was quite worried about some hair loss that she'd had, and her last menstrual period was 5 months ago. In terms of her past medical history, on her GP record, she'd recently been diagnosed with prediabetes and hypertension. She also had hypercholesterolemia and fatty liver. And quite pertinently, she'd had an admission in 2009 at UCLH where she'd been treated for hiatal cyst peritonitis. And this had resulted in a left-sided hemihepatectomy and a lengthy ITU admission. In terms of her drug history, she was on amlodipine 10 milligrams once daily for the hypertension. She took some over-the-counter vitamin D, and she'd started taking HRT recently, which we stopped at this clinic appointment. There was nothing of note in her family history, no endocrinopathies. And in terms of her social history, she was a non-smoker, a non-drinker, and she's a sole carer for her 8-year-old daughter with autism. So on examination in clinic that day, she had a Cushingoid appearance. Her blood pressure was elevated. It was 156 over 102 millimeters of mercury. She was noted to have central adiposity with biliaceous striae, an interscapular fat pad, and there was evidence of hair loss. Despite the history of falls, there was no appreciable proximal myopathy on examination that day. So the next month, we brought her into BARTS for a Cushing's workup, and I'll just go through some of the results that we got that week. So we have 2 midnight cortisol readings that are significantly elevated, as you can see, one of 454 and one of 564 nanomoles per liter. She had a cortisol day curve done, and you can see the curve is quite flat, but she's running at cortisols of above 500 the whole time. And an ACTH series showed at 2 different time points. We've got a fully suppressed ACTH. And you can see from her urinary free cortisol, her levels significantly elevated above our upper reference range. We also did an overnight dexamethasone suppression test during this admission, and her 9 a.m. cortisol the next day was 684 nanomoles per liter. So we brought her imaging for review in the radiology MDT. And it showed a right-sided 3-centimeter adrenal mass. And this looked to be completely inseparable from her liver. And the decision made at the MDT that morning was for further MRI and then a surgical review. At this point, we started her on some metyrapone to help with her symptoms. So she started a dose of 250 milligrams in the morning, 250 at lunchtime, and then 500 milligrams at night. And we discharged her home. We brought her back to our day unit in March, so the next month, and we did a cortisol day curve on this metyrapone dose. And as you can see, we're not quite getting perfect control, but her cortisols are improved, but they're running a little bit high, particularly in the evening. So she comes back to clinic, and this is in April, and she's doing okay. So her blood pressure is much better. It's 129 over 89. And she reports actually her mood and her sleep have improved. And she didn't notice these were a problem in the first place, but she does feel that they've definitely changed for the better. Her periods have now returned, and she's lost 9 kilograms in weight. But she's struggling on the metyrapone. She's getting quite a lot of nausea, and she's just not tolerating it particularly well. So we reduced her dose to nothing in the morning, 250 milligrams at lunch, and 500 milligrams before bed. So she then goes and sees our surgical team, and they've reviewed her imaging. And the surgical approach appears very risky. The mass looks like it's completely adhered to the right side of the liver. And our endocrine surgeons sought opinion from the HPB team at Royal London. They had a look at all the imaging as well, and they felt that surgery was too risky. I think then our endocrine surgeon spoke to the endocrine surgery department here, who'd also discussed it along with the HPB team here at Hammersmith. And the question was posed that would a posterior retroperitoneal approach be feasible? The surgery team here, I think, felt that that's not a feasible approach, but they had thought that they might be able to go ahead with the adrenalectomy here, but it would not be without significant risk. And they've got some new imaging in the meantime, which showed the right adrenal was completely embedded in the liver with some very indistinct margins. So what do we do? So we have continued medical management, but she's not tolerating the metyrapone well, and she's really not keen to go ahead with it. Or we could consider surgery, and she was discussed extensively, and it was felt that the risk of life-changing injury or death was too high to consider surgery. Or is there another option? So We spoke a bit about this morning. Just looking through the literature, there's quite a bit about radiofrequency ablation for adrenal adenomas, but mostly in patients with primary aldosteronism. I think Jess spoke about the Fabula study. So this is a comparison of radiofrequency ablation versus surgery for primary aldosteronism, but it was for left-sided adrenal nodules only, with an endoscopic ultrasound-guided approach to radiofrequency ablation. The left adrenal gland seems to be easier to access, and there's lowest anatomical and vascular risk. Then looking again, the WAVE study, which again was discussed this morning, is ongoing. Still looking not at patients with adrenal Cushing's, but patients with primary aldosteronism. However, they are using radiofrequency ablation on both left and right-sided adrenal nodules and using CT-guided radiofrequency ablation for the right-sided adrenal lesions. Looking at radiofrequency ablation for adrenal Cushing's in particular, there's not too much in the literature. I found a small case series of 9 patients with functioning adrenal adenomas. 7 of them had PA, and 2 with adrenal Cushing's were treated with radiofrequency ablation, albeit successfully. And there was 1 case report of 1 patient successfully treated with radiofrequency ablation for adrenal Cushing's, and then a small case series of 4 patients with adrenal Cushing's treated with radiofrequency ablations, but these were all left-sided lesions only. So this lady underwent a CT-guided radiofrequency ablation, and she had this at the Royal London in January of last year. She required 2 attempts at ablation to cover the entire nodule, and she tolerated the procedure well. However, there was some post-procedure nausea and vomiting, so she was started on 50 milligrams of IV QDS hydrocortisone to cover her. She was discharged home the next day on 20 milligrams 3 times a day of oral hydrocortisone, which we then weaned down to 10, 5, and 5 milligrams over the next week. And before she went home, we managed to take a 9 AM cortisol, which was 28 nanomoles per litre, indicating a successful procedure. So the next month, she had a brief admission to Royal London again at the beginning of February. She had some diarrhea and vomiting and some symptoms of adrenal insufficiency. She was given some IV steroids, was in hospital, I think, for a night and discharged home on oral steroids again. She then had a further 2-day admission a couple of weeks later with some abdominal pain and dysuria. At this point, because of the abdominal pain, we organised a CT abdo-pelvis just to look for a collection, but there was no collection or hematoma post-procedure, and the appearances of the right adrenal gland were reported as to be expected post-radiofrequency ablation. She had a positive urine dip at that time, and she was discharged home on a course of oral antibiotics. We brought her back the next month, and we did a hydrocortisone day curve, and this is on 10, 5, and 5 milligrams. As you can see, her basal cortisol level is low at 42, indicating the procedure is still successful. However, she did have some lower cortisol levels in between doses. So pre-lunch, it was low. And then again, pre her evening meal, her cortisol had dipped quite a bit. And at this point, we converted her onto once daily prednisolone. And this was mainly due to patient preference, actually. She wanted just to take 1 tablet a day if she could, and also just to cover the low cortisol readings in between doses during the day. And then we didn't really see her for a while, and we saw her again last week. So I'm pleased to say she's doing very well. She's lost 12 kilograms since the procedure, and her HbA1c has improved from 51 to 39. She reports much improved muscle weakness, improved skin integrity, and she says her hair is growing back. Her sleep and mood are good. And we've commenced weaning of prednisolone, and we're going to see her back in clinic again in a couple of months. And so in summary, I think in this case, radiofrequency ablation of the right-sided adrenal gland has been shown to be a safe and effective treatment for adrenal Cushing's syndrome in this patient who is unable to undergo conventional surgery. Thanks for listening.
It's like surgeons are out of business. Questions?
Just a bit about the fact that it seemed to be invading the liver. It sounded like it might be an adrenal cancer. Does that worry you slightly? Because you've got no histology after this procedure.
I suppose Yeah, we don't have any historic information. I didn't actually see the imaging myself, but just from the reports, it had said it was indistinct margins, sort of invading into
We
the liver.
did see the imaging
Oh,
because
good.
this patient was discussed at our MDT. And the patient had previous liver surgery.
Yeah, so she'd had a left
So
sided.
it made interpretation difficult. And so malignancy risk wasn't high there.
I was going to ask you a question, but that might have been answered partly. The question was going to be, what was the reason why the hepatobiliary surgeons felt that surgery was not possible? But I think Professor have answered the question that she had already had hepatic surgery, so that might have been the reason for demerral to be considered again for that. Okay. So what segments were removed during the previous hepatic surgery? Do we know?
All I can see from the notes is she essentially had a left-sided hemihepatectomy, and that was because of the hiatus peritonitis that she was treated for in 2009. I'm not entirely sure exactly what's it.
Good afternoon, everyone. My name is Danielle, and I'm one of the trainees at UCLH. Thank you very much for giving me the opportunity to present this case that we've called Walking Off the Cushings, which is a bit of a spoiler alert. But it's not a complex case per se, but we thought it would be a good opportunity to get the thoughts from the audience, and particularly the thoughts from the experts in the room. So this is a case of a 58-year-old gentleman. He was referred to UCLH in early 2023, and the referral letter stated that he had autonomous cortisol secretion and incidentally found bilateral adrenal nodules during the workup for renal stones. His past medical history was significant for hypertension. He was on a single oral antihypertensive agent of amlodipine, and he had no family history of any significant endocrinopathy, particularly that of any adrenal disease. So when we first met him in clinic, he reported a very intentional 13-kilogram weight loss over the preceding 12 months. He had done this by eating a predominantly vegetarian diet, cutting sugar out of his diet, and a high physical activity level. He was a highway patrol officer, and he was walking up to 9 miles a day as part of his job. He had no symptoms suggestive of Cushing's syndrome at all, and drank alcohol on occasions. So, to examine, he was a very slim, tall chap who was normotensive with a normal BMI, and he had clinically had no evidence of hypercortisolism. So, to move on to his biochemistry, you can see his 9 a.m. cortisol was 272 nanomoles per litre. He had 2 ACTH measurements performed, both of which were suppressed, with values of less than 1.5 nanogram per litre and 2.5 nanogram per litre. His DHEAS were not suppressed, and his 17-OHP was normal. He had no evidence of diabetes, with a HbA1c of 37 and an unremarkable lipid profile. So moving on to the biochemistry that we're all very interested in. So his first overnight dexamethasone suppression test showed a non-suppressing cortisol with a value of 208 nanomoles per litre. In view of the discordance between the phenotype and the cortisol, this was then repeated. And again, a non-suppressing cortisol of 307 nanomoles per litre. We went on to perform a low-dose dexamethasone suppression test. And as you can see, very little change in the baseline value to the value 48 hours post low-dose dexamethasone. 2 late-night salivary cortisols were raised with values of 7.2 and 9 nanomoles per litre. His 24-hour urine-free cortisol was normal. As we know, this is the least sensitive test for hypercortisolism, and so this was felt to be less important. So here you can see his cortisol day curve, and in contrast to the previous talk, you can see that actually the mean cortisol was 274, but you can clearly see a loss of the circadian rhythm throughout the course of the day till 5 o'clock. So at this point, we were fairly satisfied that biochemically he had evidence of hypercortisolemia. However, our gentleman continued to walk 9 miles a day, keeping himself very active and healthy. So to review his radiology, You can see here, these are the images from 2023. He had 2 nodules on the left they were 3 centimeters and 2 centimeters inside, and another nodule on the right-hand side, which was 4 centimeters. All 3 nodules had Hounsfield units less than 10, which were in keeping with benign adenomas. This was then discussed at the Adrenal MDT a month or so later, and they again agreed with the conclusions. So to assess the effect of the hypercortisolism on the bone mineral density, we also went on and performed a DEXA scan, which, as you can see, showed a normal T-score at both the lumbar spine and the hip. So this was going to be a Mentimeter, but we had trouble sending it across. So we're going to have to go back to a very old school show of hands. So please bear with me. And this is kind of a 2-part question. So a show of hands, I appreciate it's quite small, so you'll have to listen to my question, but what do you consider the most likely diagnosis? At this stage, do you think this is mild autonomous cortisol secretion, as we heard about in the talk just prior, or do you think this represents Cushing's syndrome? So I guess a show of hands for Max. Don't be shy. And then a show of hands for Cushing's syndrome. Okay, so a fairly mixed bag. And this is why we brought the cases, because we thought it would probably do that. So then I guess second part of the question is, again, because they're not mutually exclusive, do you think this is bilateral adrenal adenomas, or as somebody discussed earlier, do you think it could be primary bilateral macronodular adrenal hyperplasia? So a raise of hands for bilateral adrenal adenomas. And then a raise of hands for the PBMAH. Perfect. Okay, so again, a very mixed bag. Okay, so at UCLH, we had a case discussion. I've sort of summarized the main points here. So we all agreed that there was almost certainly cortisol excess biochemically. He was non-Cushingoid with hypertension, but without diabetes or any evidence of low bone mineral density. The discussion was that we felt that treatment of his hypercortisolemia at this point had no real clear benefit. And the question was raised that could walking 60 miles a day explain the lack of his phenotype? And hence the spoiler. Fine, so update. He was seen most recently in November last year, and he was still walking 4 miles a day, but this had reduced significantly from the 9 miles a day that he was walking previously. And with that, he had noticed a subsequent weight gain. However, he still remained non-Cushingoid to examine. So as you can see, over the course of 2 years, his weight has slowly crept up from a baseline of 78 kg to 87.6 kg. And that coincided with his reduction in activity. Again, you can see a similar trend with the systolic blood pressure and also with the lipid profile over the course of just 6 months in 2024. His HbA1c remained the same. So, another question. I know that I'm probably in between you and your Friday drink after work, so let's keep going. So what would be your approach to the management of this patient? And I've got 4 options here. So the first one is to monitor biochemically and clinically. Second is medical management. Third is a unilateral adrenalectomy. And fourth is a bilateral adrenalectomy. So I guess a show of hands for just monitoring and sitting tight. A show of hands for medical management. Okay, yeah. A show of hands for referring him to our friendly surgeons for unilateral adrenalectomy. And then a show of hands for bilateral adrenalectomy. Okay. Right, so the general consensus is that we would start medical management. And in this case, we did at this point start him on a nightly dose of metarapone. And we're due to see him soon in clinic. So I guess the questions that this has raised have been a lot of the questions sort of centered around a lot of the questions that we've had today that people have differing opinions on. And so I thought that the questions for the audience Maybe, do you agree that the patient's high level of physical activity may be masking the features of underlying Cushing syndrome? And as we've heard on previous talks about ACC and also for primary aldo, is there a role for functional imaging such as CETO or 131 cholesterol to look at identify a dominant adrenal lesion if surgery was to be considered in the future? And leading on to the next talk, so I think this will remain unanswered until then, what is the role of ARMC5 testing in patients with bilateral adrenal nodules? And finally, how would you have approached the management of this patient? Thank you. Any questions?
So did you do AMC5 testing?
We didn't. We didn't.
You didn't.
No.
I would have AMC5 tested this patient.
Yeah.
Because my experience is, I was also wondering, when did the father die of heart attack?
Oh, I don't actually. We don't.
I think that's a very important thing,
Yes.
like because Jérôme Bertherat told me when he did the first cohort of this. I mean, you know this also very well, Lucas. They obviously right away after the discovery of the gene wanted to reach out to the parents to see how it's inherited. Turned out like 85% were dead and died middle-aged. So it's a very important history question. When did the father die? And typically they die between 50 and 70. Yeah, like and basically either it needs to be an effective treatment. We have to see how metyrapone is, or they do better to say goodbye. Yeah, like sort of because they will die. And the typical thing is that they actually look not so Cushingoid. Yeah, but you are then very impressed how they change after they have been surgically treated. Yeah, that's my 5 pence.
Thank you. I appreciate it.
Got a question. There was quite a discrepancy between your base dexamethasone cortisol levels and the urinary-free cortisol, also the salivary cortisol. Did you do dexamethasone levels?
No, we didn't do dexamethasone levels. No, didn't.
So good afternoon, everyone. My name is Maria Batul, and I am endocrinology and diabetes SPR. And today I'm going to present a case of ARMC5-associated primary bilateral macronodular adrenal hyperplasia. There has been some discussion in the recent case and a case before. So this case highlights the diagnostic challenges, genetic insights, and excellent medical management, long-term medical management outcome. So our patient, a 45-year-old female, presented in 2013 with NSTEMI. During her cardiac workup, she was incidentally found to have bilateral adrenal nodules, which can be seen on the transverse section of the CT scan on the slide here. The next slide shows the coronal view of the CT adrenals demonstrating bilateral adrenal nodules. This incidental finding became clinically significant when further history and evaluation was suggestive of significant cortisol excess. Past medical history, she had long-term hypertension and diabetes, had hemithyroidectomy for benign nodule, and on this instance, she presented with ischemic heart disease. Looking at the medication history, she was on extensive cardiovascular and metabolic therapy, suggesting cardiometabolic burden. On direct questioning, she had the typical symptoms of Cushing's, including weight gain, disturbed sleep, irregular menstrual cycle, and she had the stigmata of Cushing syndrome on examination, including adiposity, striae, bruising, periorbital puffiness. This led to hormonal evaluation. Her baseline cortisol was high at 600, which failed to suppress at any doses of dexamethasone. Pituitary profile was normal, and plasma, aldosterone, renin, meta-adrenaline, and normeta-adrenaline were all normal. Further investigations included corticotrophin-releasing factor test, which showed suppressed ACTH, and no rise in cortisol, with a baseline cortisol of 499 nanomoles per liter and a peak of 543 nanomoles per liter, confirming ACTH-independent Cushing. Urine steroid profile showed high levels of cortisol metabolite. There was no evidence of congenital adrenal hyperplasia or adrenocortical carcinoma. So our patient had both clinical and biochemical evidence of ACTH-independent Cushing's or adrenal Cushing's due to bilateral adrenal nodules or macronodular hyperplasia also known as AIMAH previously and PBMAH presently. She was then commenced on medical treatment with metyrapone as a bridging therapy before she could proceed to bilateral adrenalectomy, but she showed an exceptional response to the medical management. She was commenced on metyrapone 250 milligram 3 times daily. She lost 6 kilograms of weight. She discontinued her diabetes medication due to hypoglycemia. She became less cushingoid in appearance. Mean cortisol levels on Dacre were 240 nanomole per liter. So this shows an excellent clinical and biochemical response to medical treatment. She's currently on 500 milligrams twice daily and has shown excellent response for over 10 years now. So this led to further evaluation of the pathophysiology of PBMAH, which was first described by Kirshner et al. In 1964. It is characterized by the presence of bilateral adrenocortical benign macronodules larger than 1 centimeter that present with variable levels of excess cortisol secretion. Over the years, it has been known via various names, as I've mentioned before, AIMAH, which is ACTH-independent macronodular adrenal hyperplasia, BMH, PMH. It comprises 1 to 4% of bilateral adrenal lesions, and it is believed to be a rare cause of ACTH-independent Cushing's, accounting for less than 2%. It typically affects between the ages of 40 and 70, and it predominantly affects females. Previously considered an ACTH-independent Cushing syndrome, it now appears that cortisol secretion by the adrenals is regulated in a paracrine manner within the cells in the hyperplastic adrenals. Furthermore, adrenal aberrant receptors stimulate cortisol secretion via non-physiological pathways, including GIP, beta-adrenergic receptors, serotonin, glucagon, angiotensin, vasopressin, LH, and HCG. So our patient was also assessed for aberrant receptors and showed no cortisol response to mixed meal and to posture change. On the right-hand side of the slide there, it's an in vivo screening protocol for the detection of aberrant adrenal hormone receptors, which lasts for 3 days, and cortisol response is checked against various stimuli, including postural change and mixed meal during day 1, GnRH and TRH at day 2, via glucagon and vasopressin at day 3. A few words about the genetics. So previously believed to be sporadic, PBMAH can rarely be associated with hereditary syndromic diseases like MEN1, familial adenomatous polyposis, hereditary leiomyomatosis, and renal cancer. Familial cases exhibiting an autosomal dominant pattern led to the identification of ARMC5 gene, known as armadillo repeat containing 5 on chromosome 16 as pathogenic. The table on the right-hand side shows that there are lots of other genes which are associated with the condition, one of which could be of significance is KDM1A, which is associated with myeloma and MGUS. So around that time in 2013, a New England Journal of Medicine published an article linking ARMC5 mutations with macronodular adrenal hyperplasia with Cushing syndrome, and we were aware of this link, and we referred our patient for the genetic testing, but was not clinically available at that time. Down the line in few years, it became available. It can now be requested via NHS Genomic Medicine Service. The clinical code for this is R160. It comes as primary pigmented nodular adrenal cortical disease. Our patient did not have PPNAD, but one of the eligibility criteria is the clinical diagnosis of ACTH-independent Cushing syndrome of unknown etiology. So the association of ARMC5 gene mutation was first described in 2013. ARMC5 mutations are responsible for 20 to 25% of the apparent sporadic cases and a larger number of familial cases. Our patient underwent testing by the NHS Genomic Service and was confirmed to have germline ARMC5 mutation. Emerging evidence suggests that ARMC5-associated PBMAH may be particularly responsive to metyrapone, exhibiting long-term disease control and avoiding the need for unilateral or bilateral adrenalectomy. And there have been a few cases reported for this. Our patients' long-term stability favors this strategy. Interestingly, ARMC5 mutations have also been linked to meningiomas through second hit mechanism and through loss of heterozygosity. Interestingly, this association is becoming increasingly recognized, and literature review shows a few cases reported with it. In keeping with it, our patient had an MRI brain which showed a Petrus-Ridge meningioma, which is being managed conservatively. So the key takeaway from this case are PBMAH is a rare cause of Cushing syndrome associated with ARMC5 gene. Metyrapone can offer excellent long-term disease control, potentially avoiding adrenalectomy and long-term cortisol replacement. Offer genetic screening to family members to detect affective members and provide early detection of PBMAH to prevent the insidious effects of progressive cortisol excess. Neuroimaging should be considered due to association with meningioma. Hello.
Thanks. Hi. Thanks, Maria, for that presentation. That was great. Yeah, it's a surprise to us that she responded really very well to metyrapone, and we never thought that that was only supposed to be a bridging treatment, but she was incredibly happy and clinically sustained on metyrapone, which I don't use as a BD drug. I mean, it's normally a 3 or 4 times a day drug, so it's very odd clinical story, but she is doing well. I was interested to hear what Vipka said about the mortality, but it was 13 years ago she was diagnosed. So I don't think she would go for surgery at the moment. Her sons have been referred for gene testing.
Thank you. So BEMA has a very lengthy protocol, 3 days, and I remember last updating it about 10 years ago. And everyone got excited when Lacroix published that New England Journal saying with a beta blocker, you can treat Cushing's if there's aberrant beta receptors. Has anyone here managed to treat someone with BEMA with one of these blockers like a beta blocker? Or is there any merit in doing this lengthy protocol?
I have a piece of answer. In Paris, in Cochin, we used to have, they still have, a patient with ARMC5 mutation and aberrant expression of beta-adrenergic receptors, which is treated with propranolol for 25 or 30 years with a perfect control of cortisol secretion. This is one example, and I think André Lacroix is also a patient who has been treated for 30 or 40 years successfully with propranolol. This is the only aberrant receptor that can be efficiently targeted with specific medical therapy. The other receptors cannot be targeted. So except for the JAP receptor, just for a few weeks or months, probably the somatostatin analogs can be efficient, but not just transiently.
Luca, do you have any comments on the response to medical treatment, so low-dose metyrapone or silodostat?
Yeah, we sometimes see some patients responding very well to metyrapone and small doses of metyrapone, so that's quite surprising. But we see the evolution of the therapeutic management of this patient. Less and less PBMAH patients are operated, and which is a problem for research because we'd like to have access to the tumor samples to do our genetics stuff. But yeah, not a lot of patients are well controlled with metyrapone.
Okay, thank you very much. Thank you, Maria.
Thank you.
Now we have Sean Thomas, the Departmental Surgical Fellow 2025, who's going to present an unusual case of congenital adrenal hyperplasia.
Good afternoon, everyone, and thank you for this opportunity to present this case in this esteemed forum. it is an interesting case because there's only a handful of cases which have ever been reported in the literature. The title of my case is When Androgen Excess is Not Benign, ACC in a Non-Classical Congenital Adrenal Hyperplasia Patient. My name is Sean Thomas and I'm a senior clinical fellow in the Department of Endocrine Surgery. This patient was managed by the Departments of Endocrine Surgery and Endocrinology at the Hammersmith Hospital. This photo is not as dramatic as the one in the morning, but this is a lady who was 59 years of age who presented to us with a recent onset of hirsutism, which was there for the last 18 months. She had history of thinning of her hair. She had grown a beard, which was not there earlier. She also had symptoms of hypercortisolism, such as she did not have striae, but she had thinning of her limbs. She had gained weight. She also had poor control of her hypertension, which required increase in her antihypertensive dosages. Her past history included she was diagnosed with congenital adrenal hyperplasia, which was non-classical at the age of 21 years of age. She was on a reverse cortisol placement wherein she was at 2.5 milligrams in the morning and 5 milligrams in the evening. She also had a history of carcinoma of her left breast managed in 2017 and an ASD shunt, atrial septal defect with a left-right shunt, surgery of which was done in March of 2025. This is what the test results. So this is what the investigations were when she was referred to us, which showed that her testosterone levels were very high. Her testosterone to sex hormone binding globulin percentages were very high. Diagnosis of congenital adrenal hyperplasia were confirmed because of high levels of 17-alpha hydroxyprogesterone levels, and her DHEAS levels were also very high. She was seen in a joint adrenal clinic and she was planned for further evaluation with functional studies and imaging. This is what the imaging done showed. So as you can see here, there was a large tumor which is about 7.6 centimeters, heterogeneously enhancing lesion with areas of calcification in the lesion, which is arising from the lateral limb of the left adrenal gland. Surprisingly, her right adrenal gland looked normal on the scan, even though she had a diagnosis of congenital adrenal hyperplasia. This is another image, cross-sectional imaging, which showed that it is closely abutting the tail of the pancreas, and this is a coronal section showing it is closely abutting the renal vasculature. We proceeded to do a FDG PET scan for her, which showed an intense activity in the left adrenal gland with an SUV of close to 23. There was no other sites of metastasis, and there were no lung mets or any other mets anywhere else in the body. She was advised admission under the endocrinology care. However, because of logistics, she preferred to be an outpatient. However, within 3 days of us seeing her, she was admitted to the local district general hospital with peritonitis, which was secondary to sigmoid diverticular perforation. She underwent laparotomy and a Hartmann's procedure with a stoma, which was on the 1st of November of 2025. Her consultants back in DGS consulted the endocrinologist, Dr. Florian, and she was started on postoperative metyrapone because of her high levels of cortisol, and she was changed to block and replace regimen because she developed refractory hypotension, hyponatremia, and hypoglycemia in response to the metyrapone, and she was on block and replace regimen. Once she was seen by us and managed by us, this is how we managed her in terms of we started her on metyrapone, and this is the evaluation that we had here. So this is her baseline cortisol when she first presented to us at a level of 629. With the introduction of metyrapone, it drastically fell and came down to 157. But then when we tried to hike up the dose, she developed intractable nausea and vomiting and was not tolerating a hike in her dose. And that is when we had to stop the metyrapone, and it reflexively jumped up to 542. That is when we started her on oscillodose, and then we can see that it progressively tapered over the next 1 month, wherein she was rehabilitated and we could intervene and we were able to operate her. And this is what her postoperative steroid level, cortisol level was. Again, this is prior to surgery, wherein we can see that her DHEAS levels were very high, testosterone levels were continued to be high, and her 17-alpha hydroxyprogesterone level was high. She was managed under endocrinology with cortisol-lowering therapy, as I said, with a block and replace regimen, initially with metyrapone for 500 milligrams thrice a day. However, this could not be uprated because of her nausea, and she was changed to oscillodose, which was well tolerated. She required intense nutritional supplementation and physiotherapy, which lasted for more than a month because of after her first surgery, which was her Hartmann's procedure. Finally, she underwent an open left adrenalectomy. Intraoperatively, the operation was difficult. She had a lot of dilated veins all over her abdomen, secondary to her underlying Cushing's. She had intraoperative adhesions of the tumor to the pancreatic tail. However, this could be dissected free by blunt dissection. Postoperatively, she required injectable hydrocortisone, which was later changed to oral prednisolone. Postoperative course was stormy. She had a prolonged ileus, gave us a couple of sleepless nights. We had difficulty in ambulating her. However, we were managed to mobilize her, and she was discharged home on the 14th postoperative day. Her histology, we were anxiously awaiting for her histology to see what this is going to be, even though we had high suspicion that it's going to be an adrenal cortical carcinoma. The histology was reported as a 302 gram tumor, which measured about 75 millimeters in size with extracapsular extension. It was labeled as an adenocortical carcinoma, oncocytic type, which is a low grade. The Lynn-Weiss vesicular scoring system was used for categorizing the oncocytic type of tumor because the Weiss criteria cannot be used in the oncocytic type. She had presence of vascular venous invasion, and she had necrosis, lymphatic invasion, and capsular invasion. Tumor was classified as a T3 disease, no lymph nodes. However, Ki-67 index, even though it was a low-grade tumor, was at 50%. These are the histological pictures where you can see oncocytes arranged in large nests, high mitotic index, vascular invasion, where you can see tumor in the vessel wall, and extracapsular extension, wherein the tumor is extending beyond the capsule of the adrenal gland and extending into periadrenal adipose tissue. All her markers for adrenal cortical markers were positive. And as I said, she was staged at T3, NX, and NX, M0. She is planned for adjuvant mitotic in view of her high Ki-67 index. Just a short note about congenital adrenal hyperplasia. It's an autosomal recessive disorder. It is because of pathogenic variant in the CYP21A2 gene. It causes enzyme deficiencies in production of adrenal hormones, and it results in upstream negative feedback and persistent elevation of this ACTH. 91% of this is because of this 21-hydroxylase deficiency, which causes the elevation in the ACTH levels. Also, it results in low to normal levels of aldosterone and high levels of androgens. CH, as we know, can be of either forms, classical or non-classical. Our patient had non-classical CH, wherein the enzyme activity is not as severely impaired, and that is why she was diagnosed at the age of about 21, and causes a reduction in enzyme activity of about 20 to 50%. Can present with excessive hair growth and menstrual irregularities. Inadequate suppression of ACTH is believed to cause a neoplastic transformation of the adrenal cortical tissue. Most of them are myelolipomas or benign adenomas. Prevalence of adrenal tumors in congenital adrenal hyperplasia is seen in about 30%, and in genetically confirmed CAH is seen in about 23% of cases. Link between CAH control and development of adrenal tumors is known, and this is because of high prevalence in those patients who present with late diagnosis and who are non-compliant with treatment. Also, cessation of glucocorticoid therapy in patients with CAH causes long-standing ACTH elevation and induces adrenocortical hyperplasia, which can result in tumorigenesis. This is believed to act as a growth and metaplasia-inducing factor. A short note on oncocytic adrenocortical carcinoma. It's a very rare subtype. It's classified as the Lynn-Weiss vesicular scoring using the Lynn-Weiss vesicular scoring system. Because if you use the Weiss scoring system, most of these tumors will be having a high Weiss because of the oncocytes which are present in them. The major and the minor criteria are here. It has a better prognosis as compared to adrenocortical carcinoma. And these are the handful of cases which have been reported which have CAH associated with ACC. So awareness of CAH and adrenal tumor combination is necessary, either starting from patients who receive a diagnosis of an adrenal tumor or of CAH. And possibility of an adrenal tumor in a patient with CAH being carcinoma should not be overlooked, because most of the times we think that most of these tumors are benign and we discount it. But this is something that you should always consider at the back of your mind.
Can I just make a comment on a lovely case presentation and very important message? Asilidostat is not widely available in this country, and Florian and I are working together with the Department of Health and various members of Houses of Parliament to try and get this as case, because we lag behind other European countries in not widely being able to prescribe this very effective drug. And it's something which the drug company feels very aggrieved about, and I think rightly so. And we're trying to move it forward in the right direction for the endocrinologists in this country.
Thank you for that. And it's really important. This patient couldn't tolerate metarapine, and after the first operation, she needed to recover. Her appetite was terrible, so she couldn't eat. And after we switched her to asilodostat, she was a different person. She started eating, and we could control her cortisol. So it's really important.
Good afternoon, everyone. I'm James McFarlane. I'm a research fellow in Cambridge, and I'm going to present the provocatively entitled "Is Cure Ever Possible in Metastatic Adrenocortical Carcinoma?" on behalf of Ruth Casey, Mark Cannell, and the Cambridge team. So it starts with a 46-year-old woman who presents to the emergency department with acute onset severe abdominal pain. It's a bit more towards the right, but it's quite diffuse. She's vomited a couple of times. In her background, she's got endometriosis, but doesn't take any regular medicines. She's hemodynamically stable, and on examination, her abdomen is a little bit tender, but there's no guarding or peritonism. In the emergency department, she has a pregnancy test. She's not pregnant. She's only got 1+ white cells in her urine dip. She's mildly anemic. She's got a neutrophilia. Her amylase is within reference limits in terms of other differentials. And she's got a slightly elevated lactate as well. All of these by her a CT scan of her abdomen. And here are some images. So she has this 7-8 centimeter right adrenal lesion. It's got evidence of hemorrhage, and not just contained within the adrenal capsule, but in the retroperitoneal area as well, and around the right kidney. This is enhancing, though, so suggestive of an underlying mass rather than just hemorrhage into the adrenal capsule. So quickly, here's some data about adrenal hemorrhage from the team at the Mayo Clinic. Vast majority of it is incidental, interestingly, so probably only about a quarter of it presents with acute onset abdominal or back pain. Most of the time it relates to interventions or trauma, but in a small proportion of patients it can have a more sinister underlying cause. And where there is a clear, discrete underlying adrenal mass, very likely to represent a malignant process. So 133 cases in this series, half of them were pheochromocytomas, 20% were malignant lesions, so ACCs and other extra-adrenal metastasis to the adrenal. So she gets admitted to hospital because she's in pain and she's got this new grossly abnormal finding. She's observed for a few days. She remains hemodynamically stable. Her hemoglobin doesn't drop. There's no need for acute intervention. Her pain is controlled with opioids. She's seen by endocrinology because she's got an adrenal lesion. No overt signs or symptoms to suggest a hypersecretory syndrome. Relevant biochemistry is collected, but not resulted, the majority of it, and she goes home with a view to early outpatient follow-up. So here's some of the biochemistry as it came back. ACTH is non-suppressed. A single UFC is normal. It's got a markedly elevated DHEA, which is worrying for an adrenocortical malignancy. Normal metanephrines, middle-of-the-road renin. And a urine steroid profile that was collected during the inpatient stay also comes back and is suggestive of adrenocortical carcinoma. So she's been diagnosed with an ACC that's presented with acute hemorrhage. She has an FDG PET-CT to stage her disease. Here's the MIP. Looks to be localized disease at this stage. So we can see the uptake within the adrenal lesion, physiological uptake within the renal collecting system, but nothing extra-adrenal at the time of this FDG. So provisional plan is made to aim for curative surgery. This is a young woman in her early 40s who was otherwise fit and well. Seems to be only one site of disease, but there's concern that surgical intervention straight away is going to be more technically difficult. So hemorrhage leads to an inflammatory response. The thinking of our MDT was that that will make intervention a bit trickier. The tissue planes might be more difficult to discern. There might be a higher risk of vascular injury, might be more difficult to achieve an R0 resection. But the plan is to wait 4 weeks or so, let the bleeding and the inflammation settle down, and then hopefully to perform a curative adrenalectomy. She has some interval surveillance imaging, hopefully with a view to seeing resolution of the hematoma, but sadly, there's the appearance of a plethora of new hepatic lesions. She's got multiple liver mets in this short period of time that weren't seen on the very contemporaneous FDG PET. So in multiple segments of the liver, in the caudate, in segment 4, possibly a small one in segment 7 as well. We go on to get some tissue. Obviously, we already have a diagnosis, but the thinking here is to prognosticate and also look for actionable somatic mutations. The patient's going to need some systemic therapy now that she's got disseminated disease. So we do take some tissue under ultrasound guidance. It's in keeping with a necrotic ACC as expected. She's got a high MIB1 proliferation index. Patchy B1 expression, as we were hearing from Dr. Casey this morning. Less B1 expression may be a negative prognostic indicator. And this sample has whole genome sequencing performed as well. Probably the most pertinent finding from this was some copy number changes in the arm. So there's a very nice paper from 2016 describing the genetic background of a series of ACCs, and they describe this particular arm copy number change as an adverse prognostic indicator. So our patient would have been in one of these noisy groups. Several molecular markers suggesting this is a more aggressive ACC. So what do we go on to do? Well, we start giving some systemic treatment. Our local, in this particular instance, the patient receives carboplatin and etoposide, so specifically not doxorubicin and a different platin. So we've opted for a more tolerable regime of chemotherapy. This has become our local practice, and it was particularly relevant to this patient. Who's a young woman in her early 40s. She's a single mother, so toxicity was, minimizing toxicity was really important here. So she has 2 cycles of that and then is restaged. The primary adrenal lesion has shrunk. Hepatic metastases have shrunk a little bit, but there's a new lung nodule, unfortunately. We get 3 more cycles of carboplatin and etoposide, then mitotane is initiated. So again, it wasn't done initially due to concerns about the toxicity of all these things at the same time in this young patient who needs to stay looking after her family, but she's tolerated the first 5 cycles well, so it now comes in. Further staging imaging, the primary adrenal lesion and the hepatic mets have shrunk again, and the lung nodule hasn't gotten any bigger. In total, she has 10 cycles of carboplatin and etoposide that are tolerated quite well. Get a mitotane dose that is just starting to become therapeutic here. And then we get some further imaging. So the primary adrenal lesion has shrunk from 11 centimeters to 7. And these hepatic lesions have dramatically reduced in size. So the biggest 2 in segment 4, that's gone from 2 centimeters to 1. It's very difficult to even make out the caudate lobe metastasis. So this is an excellent response to chemotherapy. The patient has another FDG PET. So the primary lesion has changed. A lot of it has necrosed. Whether that would have happened without chemotherapy, hard to say, but it has shrunk. There are still some metabolically active foci. And the liver lesions are not very FDG avid. So the radiologists assure me if I window it correctly, you can see them, but a relatively modest uptake. So on the basis of this excellent response to chemotherapy and one real culprit lesion remaining, the plan is to go for a surgical procedure now to remove the primary lesion. And that's what happens. So our surgical team get there. Things are still quite challenging following the previous hemorrhage. There's a lot of fibrosis and scarring. There is a clear plane between the right kidney. The liver's adherent to the mass in places, but it can be dissected. It's not invasive. The plan actually was to do a surgical initially to do a surgical resection of the adrenal mass and ablate the multiple hepatic lesions. Unfortunately, during the procedure, under ultrasound, it was felt that the ablation zone from the segment 4 lesion was probably a bit close to the bile duct, and there was a very high risk of damaging the bile duct with RF ablation. So the sort of intraoperative plan changes and moves from tumor resection plus ablation of hepatic lesions to multiple non-anatomical resections with curative intent. And then the histology comes back. It's mainly necrotic, this tumor. So probably only 10% of it was viable ACC, but as best the pathologist could tell, this was likely an R0 resection. And interestingly, there was no apparent viable tumor in any of these hepatic resections either. So advanced ACC is not a condition that you want to have. It has a very poor prognosis. The 5-year overall survival is less than 15%. There's a very limited evidence base. So best evidence that within the field is probably the FIRMAC trial that showed the superiority of EDPM over streptazocin, but there's only a 5-month progression-free survival within the good arm of the study. More than half of patients with advanced ACC are going to have progressive disease within 6 months, despite starting their first-line therapy. And really, beyond EDPM, there's not a lot of good evidence for picking one agent over the other. And guidance suggests really looking at the molecular profiling of the particular tumor that you're dealing with and looking for any actionable mutations. Because of these limited evidence base for the systemic treatment options, there's growing interest in cytoreduction to the primary tumor, whether that be surgical or ablation. Again, this is from the recent Lancet review by Martin Fastenack, just showing possible treatment algorithms and where our patient sits on it. So was the disease amenable to radical resection? No, when we saw the liver metastases initially. There was nothing to suggest that this was indolent. There were more than 3 lesions, so we went for standard chemotherapy, continued to follow it up. But I think the important bit is the novel bit of this case is continue to reevaluate whether you can come back to surgical resection. What else is there in the literature in this regard? Well, there's a single center in Italy who reported 58 cases of patients with either NSAT stage 3 or 4 ACC. They all started with EDPM, and then their ongoing management depended on the radiological response. Those that were either stable or responded, well, a significant proportion of them then went on to have surgery, and they did better. This isn't necessarily evidence that surgery in this setting is more efficacious per se. It does sort of select for the patients that are potentially going to have a better prognosis. It leaves the unanswered question, what would happen if the patients that responded well to EDPM initially just continued having it? But it's a signal that there may be value in surgery in this cohort. And again, some more data from American database series. So 4,788 patients with ACC, 1,198 of whom had metastatic ACC. It's retrospective data. It's sort of vulnerable to selection bias, but in matched patients, so patients matched on the size of their primary tumor, those who had resection, those who had surgery did better than those without surgery. And again, matching for the number of metastases, those that had metastectomy did better than those that just had surgery to the primary tumor. So there is some signal that removing the primary tumor mass is of survival benefit to patients with metastatic ACC. Just to return to our case, so 3 adjuvant cycles of carboplatin after primary surgery. We repeated the USP, as mentioned this morning. Serial measurements can be helpful to look for recurrence or to restage your patient. That was now normal. And yeah, no new liver metastases have appeared, and this lung nodule has remained stable at more than 12 months following primary surgery now. She continues on mitotane. Yep, just showing this adrenal nodule, this lung nodule has been stable over the past 18. So to summarize, I showed you a 46-year-old woman who presented with a hemorrhagic adrenal lesion. This was an ACC. Unfortunately, before primary surgery, liver metastases declared themselves. She had 10 cycles of carboplatin etoposide with mitotane prior to primary surgery, 3 cycles of adjuvant chemotherapy, and radiologically things are very stable. So in select patients with non-functioning metastatic ACC, particularly those who've demonstrated a response to first-line chemotherapy, primary surgery may offer a survival benefit. And this is the key people who are involved in her care. So Dr. Ang was the oncologist, and Vasilis was the surgeon in Cambridge. Thank you very much.
Thank you, James, for these excellent presentations. Are there any questions from the audience?
Beautiful case and very difficult. Your biopsy initially, the genetic, did that change your management plan in the first place? So that's question number 1. Number 2 is with the liver resection, they didn't show metastases. Were you surprised by that?
Yeah. So in terms of the original the biopsy and the genetic profiling, did that change management? Well, she's had very aggressive chemotherapy, I guess. So would we? It probably hasn't changed our specific management, I don't think here, but in someone who was a young person where you want to give systemic treatment, this is very prognostically poor with them given the most aggressive evidence-based chemotherapy. And in terms of why was the tissue within the liver metastases dead? I think it was just how efficacious the response to the chemotherapy has been, really. I think it's just that, and it was surprising. We took them out because we thought there was viable tissue in them.
Perhaps Professor Plazagan had come in here. So does the mitotane and other chemotherapeutic agents per se induce a dysplastic reaction around the tumor area, which could make the tissues relatively inhospitable when it comes to surgery?
Is that a question to me?
Yeah.
So not the mitotane, but maybe the chemotherapeutic agents can do that. I can see why they might necrose. But I mean, this case is very interesting because we are quite nihilistic when it comes to metastatic adrenal cortical carcinoma. And we've had some cases where we've really sought advice from elsewhere to say, should we be operating on a patient with metastatic disease? And generally speaking, the view is no, generally speaking. But of course, when you're dealing with a patient in the 30s or early 40s, you will do everything you can because also you're encouraged to do so by the patient. And I think what you've done there is, quite incredible, really. I think your decision making is excellent too, because I agree totally. If you have a bleed into an adrenal tumor, you've got to hold your nerve because going in fresh, it could be pretty ugly. So I don't know if you just got lucky or possibly it's gone well. And how long has this patient been going now?
About 12 months post-surgery. Relatively early days.
Of chemotherapeutic agents in such situation as in other cancers. I think immunotherapy is coming into the fore quite a lot.
Yeah, there are individual reports about the use of immunotherapy, but so that's all. We have not, to my knowledge, I don't think we've used it successfully.
Yeah, just in light with that, with the immune checkpoint, the data is not very, the small numbers, and it hasn't been very convincing. And I suppose comes back to the disease heterogeneity and sort of trying to understand maybe cortisol effects and perhaps resistance to ICIs. I suppose probably just to mention there is a study that's being set up around a Wnt peptide inhibitor that's being led out of King's and GSTT by Prof Sarker, an oncologist. And it's a CRUK trial, so many people might know about that as well, which is sort of is for people with locally advanced metastatic with disease. And it's complex. It's intratumoral injections. It's come from a previous trial, which was a solid tumor trial. Yeah, so come back to your point, not much success, it seems, from the literature around immune checkpoint.
Thank you very much to all the speakers, to the expert speakers, everyone who has contributed to this really exciting day. And there's a feedback QR code.
And certification.
And a certification otherwise once you filled in the feedback. And I hope you enjoyed it and come back next year. Thank you.